Hello, hello. I restarted it. I hope now it will work properly. Long before, not now. Yeah, today I talked once. Uh, Sometimes I'm feeling very light, sometimes feeling very loaded.
Now,
I don't know what I'm feeling.
don't worry. Not to be worry. And I am with you.
Yeah, now, let's finish this one.
Okay.
How neutrophil migrate? How neutrophil arrive here? Migration and rolling along the basal wall form addition to the endothelium. Transmigration between the endothelial cell and migration into interstitial tissue through towards a chemo-attracted stimulus. And how much is the lifespan of the neutrophil? 12 to 16 hours. Abscess is a focal collection of the pus lined by pyogenic membrane, which may be caused by seeding of pyogenic organism into a cell, seeding of pyogenic organism into a tissue. Seeding of it has liquid content and solid content, water, immunoglobulin, cytokine, clotting factor, and complement, cytokine, clotting factor. Okay. Intraabdominal collection. We will
Calling.
okay, if it is drainable, we will drain by catheter, but CT guided percutaneous drainage if accessible, percutaneous drainage if accessible, otherwise open drainage, and if not drainable, we will treat with antibiotic. If drainageable, we will drain by CT guided percutaneous drainage of the abscess or by open drainage, and if not drainageable, we will give antibiotic.
Yes. Next stage.
59 years perforation in left iliac managed by Hartmann and Stoma. BP low, pulse tachycardia, heart fever, okay, high fever. 59-year perforation in left iliac managed by Hartmann and Stoma. BP low, pulse tachycardia, high fever, or septic shock.
Define septic shock.
Sepsis allows 3 points. Criteria are respiratory rate 22 or more per minute, systolic blood pressure less than 100 millimeters of mercury, and altered mental status. Quick sofa. Respiratory rate 22 breaths per minute or more, altered mental status, and systolic blood pressure 100 millimeters mercury or less. Systolic blood pressure,
What's the meaning of mucosa or cooling?
colon, simple columnar epithelium,
Layer blue mucosa.
submucosa.
Its content.
It contained a blood vessel in the form of arcades, connective tissue, and nerve. Blood vessel, connective tissue, and nerve. Blood vessel, connective tissue, and nerve.
Cause of abscess in this patient
In this patient, it is because of the perforation.
collected in pelvis,
Because pelvis is the most dependent area in standing position.
contents of cytoplasm of neutrophils,
It has lysosomal enzyme like leukocidin.
neutrophil lifespan, okay, inflammatory cells and abscess neutrophils. Next,
Hmm. Patients with known peptic ulcer disease presented with hematemesis, OGD done, showed bleeding gastric ulcer, lab showed hypercalcemia, polymorpho, past medical history, osteoarthritis on NSAIDs, smoker CKD on dialysis.
define ulcer,
It is the breach of continuity of the skin and epithelial, breach of continuity of the skin epithelium or mucous membrane due to sloughing out of inflammatory necrotic tissue.
risk factors of peptic ulcer in this patient,
In this patient, Helicobacter pylori infection, chronic long-term use of NSAIDs because of osteoarthritis and smoking. H. pylori infection, NSAIDs, and smoking.
how can NSAIDs cause peptic ulcer?
Suppression of the gastric prostaglandin synthesis by inhibition of the COX-1 and topical irritant effect on epithelium, impairment of the barrier properties of the mucosa, reduction of the gastric mucosal blood flow, and interference with the repair or superficial injury.
What is H. pylori?
It is a gram-negative microaerophilic
Next,
spiral bacteria, gram-negative microaerophilic spiral bacteria that is found in the stomach and in the antrum.
after taking gastric bypass during endoscopy, tests done to it,
Campylobacter-like organism, CLO.
describe describe how it's done.
One
Hello?
second. One second. Okay. So how it is done? How it is done? It depends. Okay. How it is done? Describe how it is done. It depends on urease production by H. pylori. A gastric mucosal biopsy is taken during gastroscopy and it is placed in the medium containing urea. An indicator such as phenol red urease produced by H. pylori converts urea to ammonia, which increase the pH, changing the color of the positive test. Okay. After biopsy, okay, which test to be done? CLO test. CLO is Campylobacter like organism. How it is done? A biopsy sample is taken by endoscopy, and then it is placed in a media which contains urea and phenol red. And H. pylori secretes urease, which convert urea to ammonia, and this ammonia change the pH, and the color will be color of the media will change from yellow to red. It indicates H. pylori is positive. Mhm.
How does H. pylori manage to survive in gastric mucosa?
By producing urease, which decrease the pH surrounding it, so the media becomes alkali.
Other tests of H. pylori.
Urea breath test and test for stool antigen. Urea breath test and test
How
for
can
stool antigen. Okay, how can H. pylori colonize in the stomach? Flagella, which allow the bacteria to be motile in the viscous, and urease, which converts ammonia, urease, which generates ammonia from the urea, elevate the local gastric pH around the organism and protecting the bacteria from the acidic pH, and adhesine, which enhance bacterial adherence to the surface tubular cell, and toxins such as CAG-A or cytotoxin assisted gene A that may be involved in ulcer or cancer development by poorly defined mechanism. Again, flagella, which allow the bacteria to be motile in the viscous mucus. Urease, which convert the urease, which convert the urea to ammonia. It increase the pH surrounding the bacteria, so it protect the bacteria from gastric acidic pH. Adhesins, which helps the bacteria to adhere into the surface tubular cell, and toxins such as cytotoxin associated gene, cytotoxic associated gene, sorry, cytotoxin associated gene, KK, that involved in ulceration.
how does H. pylori induce gastritis?
It produces urease, which converts urea to ammonia, and protease and phospholipase. H. pylori induced gastritis. H. pylori induced gastritis by production of the ammonia, protease, and phospholipase. Ammonia, protease, phospholipase. Protease, ammonia, phospholipase. Protease, ammonia, phospholipase. Phospholipase causes damage gastric mucosa and causes inflammation. Phospholipase damage gastric mucosa and causes phospholipase damage gastric mucosa and causes inflammation.
Type of cells in gastric antral mucosa.
Gastric antral mucosa, simple columnar gastric antrum. In the gastric antrum will be the columnar cell. Yes, columnar cell with the goblet cell.
Types of gastric cancer caused by H. pylori.
Adenocarcinoma and myeloma.
Immune endocrine associated.
Hashimoto thyroiditis.
How to treat symptomatic H. pylori.
We give triple therapy, that is full dose of PPI with metronidazole 400 milligram with clarithromycin 250 milligram, or we give full dose of PPI with amoxicillin and clarithromycin 500 milligram. Both antibiotic we give for 7 to 14 days. CMP and CAP. CMP, clarithromycin, metronidazole, and proton pump inhibitor, or clarithromycin, amoxicillin, and proton pump inhibitor.
Okay. mechanism of action of proton pump
It
inhibitors?
it binds irreversibly to hydrogen potassium ATPase and thus the gastric parietal cell on gastric parietal cell and blocks the secretion of hydrogen ion into the stomach lumen, which prevent the formation of HCl.
What's the action of gastric HCl?
It activates pepsinogen to pepsin. It provides optimal pH for the pepsin and stimulates small intestine to release secretin and CCK, and it enhance absorption of the calcium and iron in the intestine, and it has antimicrobial property. Activates pepsinogen to pepsin, which helps in proteolysis. It provides optimal pH for the pepsin and stimulating small intestine to release CCK and secretin, enhanced absorption of the calcium and iron in the intestine, and it has antimicrobial property.
Mm. What are the other possible causes of hematemesis in this patient?
Hypercalcemia causes increased gastrin release. It causes increased ACL production, and more mucosal erosion causes bleeding. Hypercalcemia increased gastrin release. Hypercalcemia increased gastrin release. Hypercalcemia increased gastrin release. Hypercalcemia increased gastrin release, and it increases ACL production, and it causes more mucosal erosion and then bleeding.
Common cause of hypercalcemia.
Renal failure, malignancy, and hyperparathyroidism. Malignancy, renal failure, hyperparathyroidism. Renal failure, hyperparathyroidism.
History of recurrent renal stone. Possible cause.
History of recurrent renal stone. Recurrent renal stone, hypercalcemia.
Commonest cause of primary hyperparathyroidism.
Solitary parathyroid adenoma. Common causes of primary hyperparathyroidism. Primary hyperparathyroidism is solitary parathyroid adenoma. Solitary parathyroid adenoma. Yes.
Meaning of adenoma.
Adenoma, it is a benign epithelial neoplasm that takes the glandular pattern.
How can the parathyroid gland be localized?
Parathyroid gland preoperatively by system AB scan and intraoperatively by frozen section. Preoperatively, system AB scan and intraoperatively by frozen section.
Where can they be found if not present in their normal location?
In the superior mediastinum, as they has the same embryological origin from the thymus, third pharyngeal pulse. Wow.
Yes. What's frozen? Okay. Can you explain more? Okay. Why paraffin-based histopathology is not convenient for intraoperative
It
pathological
takes a
testing?
week to penetrate the tissue.
To embedded, yes, paraffin to embedded through the tissue. What's the treatment of parathyroid adenoma?
Excision.
Patient underwent excision of 4 parathyroid gland. You were given the following pathological report. One gland was 0.2 Schiff cell, other three are ranging from 0.08 to 0.09 gram composed of oxophil and fat cells. What's your interpretation?
Uh, the one gland, 0.2 gram, is chief cell, and other three glands composed of oxygen cells are fat cell. Okay, okay. So it is parathyroid adenoma in one gland and involution to the other gland. Parathyroid adenoma in one gland and other gland involution.
Histological find features of parathyroid adenoma.
Mainly chief cell with parathyroid adenoma. Okay, in parathyroid adenoma, there will be mainly chief cell hyperplasia. It is chief cell hyperplasia most common, and few occipital cells. Chief cell, chief cell hyperplasia, chief cell hyperplasia with few. It is chief cell hyperplasia with few occipital cell surrounded by Non-neoplastic thyroid tissue separated by the fibrous capsule. Okay, chief cell hyperplasia surrounded mainly chief cell hyperplasia with few islets of oxybal cells surrounded by non-neoplastic thyroid tissue. Non-neoplastic thyroid tissue separated by the fibrous capsule.
How does this compare with parathyroid hyperplasia?
Parathyroid hyperplasia composed of chief cell hyperplasia with water clear cells. Composed of chief cell hyperplasia with water clear cells. Water clear
What are
cells.
the treatment of each?
Primary hyperparathyroidism treated by excision. Secondary hyperparathyroidism treated by dialysis. And tertiary hyperparathyroidism, first 12 months we treat with medicine, and if not improved, then go for surgery. So primary hyperparathyroidism, solitary adenoma treated by excision. Secondary hyperparathyroidism in chronic renal failure treated with dialysis. Tertiary hyperparathyroidism after renal transplant treated first with conservative management, but if no improvement after 12 months, go for surgery. How to
How
treat
to treat
acute hypercalcemia, hydration, forced diuresis, and by bisphosphonate by IV permethrinate and calcitonin, and stop all calcium containing drug and medicine. And if it is okay. Hydration, hydration, forced diuresis, bisphosphonate, ibipemidine, zolidronate, and calcitonin. A male patient, heavy smoker, and alcoholic with dysphagia, history of GERD, and severe weight loss in a short time. Smoker, chronic
normal estrogen
alcoholic,
level?
and dysphagia, history of GERD, weight loss, okay, so carcinoma. Normal epithelial, normal stomach, normal esophageal, okay, non-keratinized, stratified squamous epithelium,
Diagnosis
esophageal carcinoma.
factors,
For this patient, chronic GERD, smoking, and alcohol.
effect of prolonged GERD,
Prolonged GERD leads to development of the Barrett esophagus, which increase the risk of development of the squamous cell adenocarcinoma. Again, chronic GERD leads to development of the Barrett esophagus, which increase the risk of development of the adenocarcinoma.
which test you would like to do for this patient?
Endoscopy with biopsy.
What the obtained cells will tell you?
It will tell about the grade and immunohistochemistry.
The reference difference between staging and degrading.
Grading is the growth and spread by pathological view, and staging is the size and spread by anatomical view. Again, grade is the growth and spread by pathological view, and staging is the size and extent. SE, SE, size and extent in the anatomical view. SEA,
Three,
cytokeratin.
treatment option of esophageal cancer.
Esophageal carcinoma, according to the stage, if operable, we do feeding jejunostomy, esophagectomy, Ivor-Levis or McCune, and chemo radiotherapy. If non-operable, palliative treatment, including debulking of the tumor, self-expanding metallic stent, and palliative chemo radiotherapy and feeding jejunostomy.
If patient develops pleural effusion, what is the possible causes?
Spread to the either spread to the lung, spread of the cancer to the pleura, spread of the cancer to the pleura, lung metastasis, and obstruction of the thoracic duct.
Pathological test to do.
Pleural tap, pleural tap.
How to treat.
Palliative treatment by thoracentesis, indwelling pleural catheter or pleurodesis. Pleural catheter or pleurodesis. Pleural catheter or pleuroperitoneal shunt. Pleurodesis, pleural catheter, pleuroperitoneal shunt.
Patient developed enlarged supraclavicular lymph node. What will you do?
We'll do FNC or excisional biopsy.
Patient developed severe epigastric pain. There is anything you want to exclude?
Myocardial infection.
Investigation.
12 lead ECG and cardiac marker like troponin, CKMB.
What's troponin?
It is a complex of three regulatory protein composed of troponin I, troponin C, troponin T that is integral to the muscle contraction. That is integral to the muscle contraction.
Present in
Cardiac muscle and skeletal muscle. A 60-year-old lady who is chronic alcoholic was diagnosed with gastric cancer. She underwent gastrectomy and splenectomy due to iatrogenic injury. She has also osteoarthritis. Pathology report shows signet ring cell carcinoma, positive lymph nodes, R1, spleen involved.
family in 4 simple symptoms.
This is the cancer of the stomach, and unfortunately not completely removed. And the patient will require further resection and chemotherapy, and it may come back again.
What's the plan for patient post-splenectomy?
To give vaccine give vaccine for the patient after 2 weeks against polysaccharide encapsulated organism of Neisseria meningitis, Haemophilus influenza, and Staphylococcus pneumoniae, and prophylactic antibiotic to protect the patient against post splenectomy overwhelming infection. Uh, Yes, again, give vaccine for the patient after 2 weeks against the encapsulated organism, Neisseria meningitis, Haemophilus influenza, and Staphylococcus pneumoniae, and prophylactic antibiotic to protect the patient against post-splenectomy overwhelming infection.
Mention 4 important risk factors for gastric cancer.
Gastric cancer, H. pylori infection, chronic atrophic gastritis, intestinal metaplasia, pernicious anemia, family history of gastric cancer, familial adenomatous polyposis, adenomatous polyps, size more than 2 centimeter, and previous gastric surgery. Helicobacter pylori infection, family history of gastric cancer, familial adenomatous polyposis, adenomatous polyp size more than 2 centimeter, previous gastric surgery. Previous gastric surgery, family history, FAP, adenomatous polyp more than 2 centimeter, H. pylori infection.
Gastric cancer develop.
Normal mucosa turn into chronic gastritis. Normal mucosa due to chronic gastritis turn into intestinal metaplasia. It will cause dysplasia, then intramucosal carcinoma or the carcinoma in situ, then invasive gastric carcinoma. Normal mucosa chronic gastritis will turn into intestinal metaplasia. Normal mucosa due to chronic gastritis, intestinal metaplasia, then dysplasia, then intramucosal carcinoma in situ, then invasive gastric carcinoma, metaplasia, dysplasia, carcinoma in situ, invasive gastric carcinoma.
Metaplasia, dysplasia in carcinoma and cytoinsins. Meta the dysplasia. Okay. What's the commonest histological type of gastric cancer?
Adenocarcinoma 95%.
Do you know classification for gastric cancer?
WHO classification, Lauren classification, and Bowman's classification.
Mention WHO classification.
WHO classification tubular adenocarcinoma, then papillary adenocarcinoma, tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, mixed carcinoma, poorly cohesive carcinoma, tubular adenocarcinoma, papillary adenocarcinoma, mucinous adenocarcinoma, poorly cohesive carcinoma, and mixed carcinoma.
10 days after resection, the patient developed diffuse painful swelling in left arm. What happened?
It it is a deep vein thrombosis in the axillary vein.
The predisposing factor for this patient.
Hypercoagulable state due to malignancy and venous stasis from Burkitt's lymph node and postoperative. It is a symptom complex that occurs in the cancer-bearing patient uh, that cannot be explained either by local or distant spread of the tumor or by elaboration of the hormones which indigenous to the tissue of the origin of the tumor.
Do you know any paraneoplastic syndrome associated with gastric carcinoma?
Acanthosis nigricans and dermatomyositis.
How does gastric cancer spread first?
Gastric cancer, left gastric lymph node,
What are the other routes of spread?
left gastric lymph node. Other routes are hematogenous lymphatics, hematogenous transcelomic and body cavities. Direct invasion. Hematogenous transcelomic and direct invasion. Hematogenous transcelomic direct invasion.
Presents with abdominal distension, positive shifting dullness. What's your diagnosis now?
And liver metastasis.
No.
Uh, Metastasis causing malignant ascites.
Yeah. Okay. Mention two pathological tests to confirm.
Ascitic tap, liver biopsy, and tumor marker CA72-4 for the recurrence, and FANAC from the left supraclavicular lymph node.
Yeah. What would be your plan to if there is recurrence?
At this stage and the recurrence, we will go for, and also presence of this is the advanced stage. So we will go for palliative treatment, which includes feeding jejunostomy, followed by chemoradiotherapy, pain relief by opioids, and palliation of ascites by repeated tapping. Chemoradiotherapy, pain relief by opioids, and palliation of ascites by repeated tapping. CA724, FNSA, left supraclavicular lymph node, liver biopsy, or metastasis, and ascitic tap and cytology. Function causes impaired liver function, decreased synthesis of the albumin causes hypoalbuminemia, low plasma oncotic pressure, and high interstitial pressure. So, impaired liver function causes decreased albumin synthesis, hypoalbuminemia, increased hydrostatic pressure, and high interstitial pressure causes ascites. How to treat malignant ascites? Treating the underlying cause with the chemotherapy and or surgery. First, treating the underlying cause with chemotherapy or surgery. Then, peritoneal venous shunt, and cell-free concentrate cell salvage re-infusion therapy. Treating the underlying cancer either by chemotherapy or surgery, peritoneal venous shunt, and cell-free concentrated ascites re-infusion therapy. What are the procedure-specific complications of total gastrectomy, early complication and late complication? In early complication, anastomotic leak, hemorrhage, infection, pancreatitis, cholecystitis, anastomotic leak, hemorrhage, infection, pancreatitis, cholecystitis. Late complication, dumping syndrome, vitamin B12 deficiency, metabolic bone disease and recurrence of the malignancy, dumping syndrome, vitamin B12 deficiency because of lack of intrinsic factor, metabolic bone disease, I don't know, and recurrence of the malignancy. What is dumping syndrome? Loss of reservoir function of the stomach following gastrectomy result in rapid transit of highly osmolar active substance into the duodenum following the meal may cause symptoms called dumping syndrome. Loss of reservoir function of the stomach following gastrectomy, resulting in rapid transit of highly osmotically active substance into the duodenum following meal, may cause symptoms which is called dumping, categorized as early dumping within 30 to 60 minutes and late dumping 1 hour to 3 hour. Early dumping due to rapid transit of hyperosmolar gastric content into the small bowel result in fluid shift from the interstitial space into the gastric lumen, causes lumen distension, colic abdominal pain, diarrhea, vasomotor symptoms such as tachycardia and postural hypertension. Due to rapid transit of the hyperosmolar gastric content into the small bowel result in fluid shift from the intravascular compartment into the gastric lumen, causes bowel distension, colic abdominal pain, diarrhea, vasomotor spasm such as tachycardia and postural hypertension, and late dumping, which occurs 1 to 3 hours following the meal due to rapid transit of the carbohydrate into the small bowel, result in sudden absorption of high sugar level and compensatory hyperinsulinemia, resulting hypoglycemia. Yes,
What is the name of familial type of gastric carcinoma?
hereditary diffuse gastric cancer syndrome. Hereditary diffuse gastric cancer syndrome. Hereditary diffuse gastric cancer syndrome.
A gene mutation.
Gene mutation, CDH1, autosomal dominant.
You you didn't remember the previous line. Uh, Mode of inheritance.
Mode of inheritance, it is autosomal dominant.
If you have a mutation in your CDH1 genotype, gene types of cancer may be which types of cancer may be associated?
Hereditary diffuse gastric cancer syndrome. Hereditary diffuse gastric cancer syndrome. Also, prostate cancer, lobular breast cancer, colon and rectum cancer. Again, if this is a stupid question.
Hmm?
If have a mutation in if have mutation in CDH genotype of genotype of cancer which may be associated. So hereditary diffuse gastric cancer syndrome, hereditary diffuse gastric cancer syndrome, colon and rectum cancer, hereditary gastric cancer syndrome, hereditary gastric cancer syndrome, colon and rectum cancer, colon cancer, rectum cancer, lobular breast cancer, and prostate cancer. Hereditary diffuse gastric cancer syndrome, hereditary diffuse gastric cancer syndrome, colon cancer, rectum cancer, lobular breast cancer, and prostate cancer. Hmm.
Clinical criteria to select patient eligible for CDH1 mutation.
Okay, two or more documented case of gastric cancer in the first or second degree relative, regardless of the age, with at least one confirmed diffuse hereditary diffuse gastric cancer and another one diffuse gastric cancer before age of 40 years with a family history. Family with diagnosis of both diffuse gastric cancer and lobular breast carcinoma, at least one before the age of 50. Okay. Other than adenocarcinoma, other types of gastric cancer, one is carcinoid tumor, lymphoma, maltoma, gastrointestinal stromal tumor, carcinoid tumor, lymphoma, maltoma, hereditary diffuse gastric cancer syndrome, and gastrointestinal stromal tumor.
Yeah.
60-year-old male with rectal bleeding, rectal examination revealed external hemorrhoids and fecal immunochemical test 100, colonoscopy with biopsy done and developed adenocarcinoma with Melanosis coli. Histological examination of the specimen revealed lesion invading up to the muscularis propria. Patient has a history of chronic heart disease.
Okay. Okay.
Okay? One second.
How can you stay?
One second. One second.